All right. In this one, we are going to talk about serotonin syndrome versus neuroleptic malignant syndrome, two commonly tested topics because they can both appear very similarly. The management is going to differ, and these are both life-threatening conditions. So, really important to be able to tell the difference between them, whether you're an emergency medicine physician, internal med physician, pediatrics, psychiatry, right? You have the potential to see these, and they're going to be commonly tested on board exams. So, we better be able to tell the difference. We better be able to know how to treat them. So we'll discuss the pathophys, pharmacology, management of serotonin syndrome and NMS, and then we'll do a putting it all together case. So this was a case I presented on Instagram this morning. So let's work through it. We have a 34-year-old woman presents to the emergency department with agitation, confusion, and profuse diaphoresis. Her temp is 103. She has a history of opioid use disorder and frequently uses fentanyl. Over the past few weeks, she developed a cough and began taking over-the-counter cough medicine. She also has a history of well-controlled schizophrenia managed with haloperidol, which was recently increased in dose by her PCP 2 weeks ago. So I want you to consider which of the following findings would most support the diagnosis of serotonin syndrome over a diagnosis of neuroleptic malignant syndrome. Would it be lead pipe rigidity? Would it be elevated creatine kinase? Would it be fever? Or would it be clonus? So pause your screen and think about it. So it would be clonus, okay? So clonus is especially like if we think about inducible or spontaneous in the lower extremities. So we classically do it on the ankle. We have the patient just sit and I'll push their ankle back and then we'll let go. And if they have clonus, they'll have a little bit of fluttering, right? It tells me there's upper overactivity of the upper motor neurons, okay? That is very specific for serotonin syndrome in the right context, right? Patients can have clonus for other reasons, other upper motor neuron injuries, but in the right context of this patient, right? They've got the fever, they have diaphoresis, they have confusion, they have agitation, they're on fentanyl, and we're probably taking dextromethorphan, right? Which is a commonly used over-the-counter cough suppressant. Both of those together can lead to serotonin syndrome. We'll kind of talk about the drugs too. But the thing that kind of could be tricky here is she also has a history of schizophrenia, and haloperidol is a typical antipsychotic that is well known to cause a lot of our extrapyramidal symptoms and neuroleptic malignant syndrome, right? So, and she actually had her dose increase, which is usually what sets off NMS. So she has kind of two things going on here, and both NMS and serotonin syndrome can show up a lot alike. But if I saw in the patient neuromuscular hyperactivity and clonus, right? Clonus would be like a subset of neuromuscular hyperactivity. Then I'm thinking more serotonin syndrome. Okay. So clonus is present. It's usually absent. Actually, it is absent in neuroleptic malignant syndrome. Reflexes are usually hyperreflexive in serotonin syndrome. In neuroleptic malignant syndrome, they're usually normal or decreased. The rigidity, serotonin syndrome, not really super rigid. But in neuroleptic malignant syndrome, they classically have this lead pipe rigidity where they're literally going to be stiff as a board. Okay. Um, the onset of serotonin syndrome is usually like pretty quick in hours, and in neuroleptic malignant syndrome, it kind of builds over days. Some common causes, right? In this case, it would have been the dextromethorphan and the fentanyl, right? Fentanyl, most people don't know this, but fentanyl can lead to serotonin syndrome if used in the right context with other drugs that increase the amount of serotonin in our synapses. Um, in neuroleptic malignant syndrome, antipsychotics, especially your typicals like haloperidol, and then fever and CK elevation, they can be seen in both, right? So the high fever in both of these cases are usually due to the muscle overactivation. And when my muscles overactivate, they can cause damage. We can get muscle necrosis, which releases CK. So usually in neuroleptic malignant syndrome, the CK is quite elevated. In serotonin syndrome, it's usually not as elevated, but both of them can be elevated and both can have a fever. What really sets me apart is going to be my neurological exam. So in serotonin syndrome, it's going to be the hyperreflexia and clonus. In neuroleptic malignant syndrome, it's going to be more of this rigidity type picture. And we'll kind of break this down further. So what is the pathophysiology of serotonin syndrome? It's due to excess serotonergic activity and overstimulation of my 5-HT1A and 5-HT2A receptors. So these are found in huge amounts in the brainstem and spinal cord. And when they get overactivated by X, Y, or Z, right? So we're giving the patient's on too many drugs that increase the amount of serotonin in my system for whatever reason. When these receptors get activated in my brainstem and spinal cord and they get overactivated, it can lead to altered mental status, autonomic dysregulation, and neuromuscular hyperactivity, myoclonus and hyperreflexia. Again, this occurs pretty quickly in less than 24 hours, and my mnemonic for you is too much 5-HT makes me hot, high, and hyper. Okay, so think really about the hyperreflexia and clonus are really, really good signs that we're dealing more with serotonin syndrome than neuroleptic malignant. Some common drugs linked to serotonin syndrome obviously are SSRIs and SNRIs, like sertraline and venlafaxine, respectively. Those are going to increase the amount of serotonin in my synapse, increase the amount of my serotonin. MAOIs do more or less the same thing. They're going to block the enzyme that breaks down serotonin, so more of that serotonin stays available for binding to receptors. I love the linazolid, right? It's fairly uncommon, but it shows up in practice questions. So remember, remind me, when do I use linazolid? So linazolid can be given PO or it can be given IV. It can be used for MRSA, and it's also commonly used for vancomycin-resistant enterococcus, right? So remember, enterococcus, it can alter the way certain drugs are moved in or moved out, and so it can alter its cell like peptide wall. It's usually D-ALA. It can change it to D-ALA-D-LAC, and that prevents vancomycin from being able to get in and do its job. Okay, so in that case, usually for enterococcus, first line is vancomycin. For if we give the patient vancomycin with known enterococcus and we're still waiting on the sensitivities and the vanco's not working, we should consider vancomycin resistant, and we can give drugs like linazolid or daptomycin, right? Daptomycin punches a hole in the outer part of my bacteria. Daptomycin cannot be used for lung infections because a surfactant inhibits or it breaks down daptomycin, makes it ineffective. Dextromethorphan, right, is an over-the-counter cough medicine that's linked to increasing the amount of serotonin. MDMA, LSD, and cocaine can all cause increased amounts of serotonin, which if used with like an SSRI, maybe the patient has underlying depression, is just asking for increased amount of serotonin and potentially serotonin syndrome. And then there are serotonin enhancing combinations. Like maybe the patient was on an SSRI and they have migraines, so their physician puts them on a triptan. Triptans are serotonin agonists, right? They usually work in the brain to cause vasoconstriction, right? Serotonin is going to help clamp down on those vessels because the pathophysiology of migraines has to do with CGRP, which causes vasodilation in my vessels in my brain, and it can cause a huge pounding of blood moving through my vessels, and that can lead to some of that pulsatile pounding that we see in migraines. So we give the patient triptans, which are serotonin agonists, and they'll clamp down on those vessels and decrease the amount of blood flow through a lot of those vessels and decrease the pounding pulsatile headache that we see in migraines. So my key concept, right, is it's usually drug interactions. It's not me just giving one drug. Obviously, it can happen, but it's more rare. If we're looking in a vignette, I'm going to probably see the combination of two drugs. Patient is on has well-controlled depression. They may not tell you with what. They'll tell you well-controlled depression. They just recently had a cough. Now you have to assume they took dextromethorphan. They just had a really serious infection. They were put on linazolid, right? Things like that. All right. These are Hunter criteria, right, which is what we use to help diagnose serotonin syndrome. So the diagnosis absolutely requires exposure to a serotonergic agent plus at least one of the following. Do they have spontaneous clonus? Do they have inducible clonus plus agitation or diaphoresis? Do they have ocular clonus plus agitation or diaphoresis? Do they have tremor and hyperreflexia? Or do they have hypertonia plus a temperature over 38 plus ocular or inducible clonus, right? Really, I don't need to think about it too hard, right? Look at the patient's medication history, talk to their family if the patient can't talk, figure out, right? Maybe you get yourself into a trouble where you're in the ED and the patient can't talk to you, right? Maybe we don't know anything about their past medical history. If I see clonus and I see hyperreflexia and I see a high fever, we immediately need to jump to serotonin syndrome, and we're going to talk about the management, right? But hopefully we'll get some sort of history and we can say, hey, this patient has a history of depression. They're on an SSRI. I do my physical exam. They've got nice clonus. I do my reflex hammer, and they've got really brisk patellar reflexes, really brisk bicep reflexes. That by the Hunter criteria, that right there is enough. We go, and we go on the management, and we'll talk about it here. So serotonin syndrome. Obviously, the right answer on any board exam, if they haven't done it yet, is stop the offending agent, right? We'll do this in real life too. Just stop the drugs that they're taking, right? We'll usually treat supportive care is go number one, right? So IV fluids, oxygen, and cooling measuring, right? A lot of the times, the board exams and in real life, right, we're going to have to consider this. They'll ask you about pharmacological therapy. This is where I see a lot of students go wrong because I'm assuming one of the like board prep books or something that a lot of students are using are telling them cyproheptadine first. If you look in the guidelines, absolutely not. I'm going to teach you what is actually done and what is actually going to be what is actually going to show up on your MBME exams. We start with benzos, right? Benzos are going to sedate the patient. They're going to put them low and slow, right? The serotonin syndrome is just huge hyperactivity of the muscles and the entire neurological system, right? Give them benzos, slow them down, and honestly, benzos take care of the problem a lot if we stop the offending agents. If the benzos on themselves are not fully cutting it, then we can give the cyproheptadine, right? Cyproheptadine is a serotonin antagonist, right? Which will obviously key in on the core pathophysiology, stop the serotonin from binding in the first place. This is really only used for moderate to severe cases. So again, we stop the offending agents, we do supportive measurings like IV fluids, oxygen cooling. We then can give benzos, and then if all that hasn't cut it, we can give cyproheptadine, a serotonin antagonist. We can admit to the ICU, right, if severe, if they have hyperthermia or rhabdo. And then we're not giving antipsychotics here, and we're not giving antipyretics, right? Acetaminophen is not going to work, right? Acetaminophen works to lower my hypothalamic set point, right? So the pathophysiology of a lot of fevers secondary to cytokine release is really due to the increased amount of prostacyclins, which will go up to my brain and they increase the hypothalamic set point, which increases my internal temperature. That's acetaminophen will work by lowering that hypothalamic set point. Is that why this patient has hyperthermia and serotonin syndrome? No. The patient has hyperthermia and serotonin syndrome because their muscles and their nervous system are extremely overactive, and it's the amount of that activity that is increasing their core body temperature, right? So we need to cool them down. We need to give them benzos. We need to put them potentially in like an ice bath or something like that we can consider, or like an ice blanket, one of those. So we're not going to give acetaminophen. It's not going to work here. All right. So that was the basis of serotonin syndrome. Let's briefly talk about neuroleptic malignant syndrome. So the pathophysiology here is due to dopamine, the D2 receptor blockade in the hypothalamus, the nigrostriatal pathways, right? So remember, what are my antipsychotics doing? They're blocking the dopamine pathways. I'll do a whole lecture on like the antipsychotics because they can get very confusing. But really at its core basis, right? The antipsychotics, they're going to block dopamine via some mechanism, right? And when we block too much dopamine, it can lead to CNS dysregulation, and we can have thermoregulatory failure. We can get huge rigidity from basal ganglia inhibition, and we're classically going to see this as slower onset over days to weeks, okay? So really what I want you to understand is the dopamine blockade, it throws off the neurotransmitter kind of like balance in my body, and it can lead to overall CNS dysregulation, which can lead to that thermoregulatory failure, and it can cause inhibition of the basal ganglia, which leads to the rigidity, okay? Remember, serotonin syndrome happened pretty quickly. Neuroleptic malignant syndrome usually takes a little bit longer, days to weeks, and it classically occurs after increasing the dose of the patient's antipsychotic. So really, drugs commonly linked to NMS, your high-potency typical antipsychotics like haloperidol and flufenazine are going to be the most common causes. But atypical antipsychotics, which have less of an effect on the dopamine receptors, right? We kind of like pulled back the dopamine blockade a little bit in these drugs. So things like risperidone and olanzapine, they can still absolutely cause NMS. They're just less likely compared to things like haloperidol and flufenazine. Remember, can you remind me what like a very common, or not a very common, but a commonly tested side effect of risperidone is? So that would be hyperprolactinemia. I'll do a whole lecture on kind of my schema for elevated prolactin levels. So risperidone is linked to elevated prolactin levels. And then what are like what's the big side effect I'm worried about with olanzapine? That'll be like metabolic syndrome, right? So elevated triglycerides, elevated blood glucose, elevated blood pressure, it can all lead to like weight gain, things like that. So we usually check that beforehand. Remember, I don't talk about it here, but clozapine is very similar to olanzapine and it's associated with agranulocytosis. We really only use clozapine in refractory schizophrenia. I'll talk about schizophrenia at another time too when we talk about the antipsychotics. Um, so withdrawal of dopamine agonists can also cause neuroleptic malignant syndrome. So it's kind of like the opposite pathway, right? So I give the patient a dopamine antagonist, an antipsychotic. I increase the dose. That's going to throw off my hormone or my neurotransmitter balance. Same as if my patient was on a chronic dopamine agonist and I just pull it back all of a sudden, that also is going to throw off the balance. Again, not as common as your high potency typical antipsychotics or even my atypical antipsychotics, but things to consider. And then one of the drugs I really love is metoclopramide because everyone forgets metoclopramide is a dopamine antagonist. It can be used in like diabetic gastroparesis. It can be used in a patient who has nausea or vomiting too. So remember, metoclopramide is a dopamine antagonist and has the potential to cause some of these extrapyramidal symptoms and neuroleptic malignant syndrome. And so remember, I'm just reminding you, we often follow a recent dose increase or a new medication where this neuroleptic malignant syndrome will occur. So what are the clinical features? Again, we've really talked about it, but it's a lead pipe rigidity, which is like pretty much pathognomonic for neuroleptic malignant syndrome. Bradyreflexia, right? So opposite to the hyperreflexia we saw in serotonin syndrome. Delirium or altered mental status, really high body temperature, right? Hyperthermia, like over 104. Autonomic instability, so we have a labile blood pressure and labile heart rate, and then super elevated CK, right? Because these muscles are going to be working way overtime in this lead pipe rigidity, right? And the muscles are going to necrose, and we're going to get the release of CK. We could potentially see leukocytosis with this huge inflammatory reaction, possible rhabdo. And again, we're not going to see clonus, we're not going to see hyperreflexia, and that's how we're going to tell it apart from serotonin syndrome. So how do we manage neuroleptic malignant syndrome? Same as serotonin syndrome to begin with, and then it changes, right? We're going to stop the antipsychotic immediately, right? Remember in serotonin syndrome, stop the offending agent. And we're going to do supportive cooling the same way we did for serotonin syndrome. We're going to do cooling, hydration, ICU. But now here's where the management differs and why it's super important we have to tell them apart. We can use drugs like dantrolene, right? Dantrolene blocks the ryanodine receptor. So in my myasthenia gravis versus Lambert-Eaton syndrome lecture, I talked about the ryanodine receptor. Ryanodine are what opens up my sarcoplasmic reticulum, allows calcium to flood out, which then can lead to muscle contraction. I talk about that whole mechanism in that lecture, so go rewatch that. If I give dantrolene, dantrolene snaps shut the ryanodine receptor. It's a ryanodine receptor blocker, so we can't get the release of calcium from the sarcoplasmic reticulum, so the muscles aren't able to contract, right? That's the core pathophysiology here. If we have basal ganglia inhibition, the muscles are just tonically contract. Let's not give the muscles the calcium it needs to contract to relax those muscles. We can also give drugs like bromocriptine or amantadine, which are dopamine agonists, right? If the core pathophysiology here is due to over dopamine blockade, right? We have too much dopamine blockade going on. Let's give them a dopamine agonist to kind of reverse that effect, right? And then again, we can use benzos for agitation. But again, you kind of see the difference, right? We start the same. We stop the offending agents. We do supportive measurements. But then for serotonin syndrome, it's benzos and then cyproheptadine. For neuroleptic malignant syndrome, it's dantrolene or bromocriptine amantadine, okay? So here's my table just showing you the differences here. So again, serotonin syndrome hours, neuroleptic malignant syndrome days. Reflexes, we're going to see hyperreflexia and clonus in serotonin syndrome. Neuroleptic malignant syndrome, decreased reflexes or normal. They're not going to be hyperreflexes. And really the rigidity, pathognomonic. Muscle tone in serotonin syndrome, we see tremor and myoclonus, right? Hyperactivity. In neuroleptic malignant syndrome, we have the lead pipe rigidity. Both serotonin syndrome and NMS are going to be hyperthermic, but we're going to see an even higher body temperature likely in NMS. The cause of serotonin syndrome is obviously increased serotonin. The cause of neuroleptic malignant syndrome is due to dopamine blockade. So treatment, again, we just talked about it for serotonin syndrome. and neuroleptic malignant syndrome, supportive and remove the offending agent, and then serotonin syndrome, benzos and cyproheptadine. Cyproheptadine, remembers that serotonin antagonist, and a neuroleptic malignant, we can use benzos as well, and then dantrolene and bromocriptine. All right, if you want to read more, here are 2 articles. This one's on this DOI is on neuroleptic malignant syndrome. It's a brand new from 2025. And then this one right here is on serotonin syndrome. So you can read more on that. Super high yield topics. Please, please, please know these for your board exams. They will show up on every board exam, I promise you. Also, please know them for real life. You can absolutely save someone's life if you run into a patient with either of these. So let's put it all together. We have a 54-year-old woman comes to the clinic for a routine follow-up. She was recently started on citalopram 10 days ago for major depressive disorder. She reports feeling a little more emotionally stable and has no new complaints. She denies dizziness, palpitations, syncope, or chest pain. Her medical history is notable for hypertension and well-controlled hypothyroidism. She takes lisinopril and levothyroxine. She recently had a bout of pertussis and was finishing a dose of azithromycin. Her vital signs are within normal limits. Physical exam is unremarkable. Her lab studies revealed normal electrolytes and renal function. An EKG is recorded at her outpatient follow-up and is shown on the next slide. So here is her EKG. Hopefully that's showing up nicely for you guys. And we will discuss. I want you to take a look at her EKG and tell me what you see. So really pause your screen. I want you to take a systematic approach of what you see. Honestly, based on the history I just gave you, you probably already know what you're looking for if you're a well-studied student. If you're not, that's totally fine. That's why you're here. And I'm going to walk you through this EKG and teach you what you need to know about this. So pause your screen and think about it, and then I'll go over it. All right. So when I work through an EKG, I use a systematic approach, and I plan on doing multiple EKG lectures. So this is not meant to be like a comprehensive, how do I read an EKG? Or like kind of like pathologies we should be looking for. Those will be coming at a later date. They take a lot of time to put through. So it's taken me a little bit to kind of think how I want to approach those. But when I read an EKG, right, first I go to one of my rhythm strips at the bottom, right? Lead 2 is usually like the go-to rhythm strip. V5 is also a pretty good one if they give it to me. So we can use V5 here. And really what I look at is the rate. And we can zoom in here to calculate the rate. If this, well, first, like we should look, I like a really good EP doctor told me, like, look at the forest before you look at the trees, right? So just look at the overall strip. Does it look regular? Yeah, it looks pretty regular, right? Do I have a P before every QRS and a QRS after every P? Yeah, so we're pretty much saying this looks like a regular rhythm and I have a P before every QRS. And then all I need to do then is look at the rate. If we zoom in, there's one really good one, maybe right around here, that lines up pretty good on a line. And if we count, right, we can go 1 box, 2 box, 3 box, 4. And there's that rule where if it's a regular rhythm, I can take 300 and divide by the number of boxes in between my R to R. So if you know the math pretty quick, right, this would be 300, this would be a rate of 150, this would be 100, and this would be about 75, right? So their rate's right about 75. So I looked at the rate. We can look at the axis, right? I look at lead 1, which is pointing up, and then lead 1 is pointing up. I look at lead 2. It's also pointing up. Lead AVF is kind of my tiebreaker, also pointing up. We have a normal axis here. It's also not really super important for this question. Then what I like to do is I like to look at my QRSs. My QRSs, again, we already said they're coming in normal at a normal rate, and they're coming in at a normal rhythm. So right now we can call it normal sinus rhythm, okay? And then I look, are they narrow, right? The QRS should be between, what is it? It's they should not be longer than 0.12 milliseconds, right? So that would be three little boxes. Sorry about that. So the QRSs should not be longer than 3 little boxes. So it's usually anywhere between 0.1 and or like 0.08 to 0.12 milliseconds. So 0.12 milliseconds will be 3 little boxes. These look nice and narrow to me. I look at the P waves. In the P waves, the PR interval should be anywhere between 0.12 and 0.20 milliseconds. So that's 3 to 5 little boxes. It's kind of hard to see here. If we zoom in a little bit on lead V5, it looks about normal. It might be pushing it a little bit on Some of them, honestly, I would totally call this within normal. If we start at the beginning of the P and we go to the end of this R, or where the R starts, that would probably be within my normal limits, right? Less than 5 little boxes. And then what I really need to look at here are my T waves, right? So if we look at, here's my R to R interval, here's the start of my T wave right here, and it finishes right where we get back at the isoelectric point, right? So let's zoom in. Finishes right where we get to the end of the isoelectric point, and I measure it from the start of my Q. There's not really a Q here, right? But this would be where the Q would start. So if we want to do our QT interval, it would be right at the start of this QRS complex to all the way to the end where the T wave gets back to the isoelectric point, right? And there's a quick rule of thumb. If the T ends more than halfway between the R to R interval, that is called a prolonged QT. And I'll give you some more details on the next slide. So right now, if we keep looking, right, Q, and there's the end of the T, it's definitely more than half, and it just continues all the way through, okay? And then I'll just take one more look, and we'll see, do we have any ST elevation, any ST depression? I'm not seeing any on V5. I'm not seeing any on lead 2. I'm not seeing any on any of my precordial leads or my inferior leads or my limb leads. So we're good there. So really the abnormality in this EKG, again, is the QT prolongation. And again, I kind of had a slip up when I was talking about the QRS. Again, it should not be longer than 3 little boxes, so 0.12. So these QRSs are narrow, so we're good to go there. So again, this patient, the QT is extremely prolonged. It looks like it's covering roughly 600 milliseconds. We can use Bazette's formula, which is the QTC equals the QT divided by the square root of the R to R interval. And if we do that, it roughly gives us a QTC of 671. The QTC corrects for the patient's heart rate. So it gives us a more like standardized level of what their QT is, because the QT can change as the heart moves faster or slower. Either way, the normal QT in males is 450. The normal QT in females is about 460. Most physicians don't usually get scared until the QT gets above like 500. We're well above 500, right? We're at least 600. So we should be a little bit scared here. So again, like I told you, roughly if the QT is above half of the R to R, that's prolonged, and we're well above that. Citalopram is the most common serotonin or the SSRI that can lead to prolonged QT. Azithromycin is a common agent as well that's known to prolong the QT. She was on both of them at the same time. That's just asking for trouble. When we have a prolonged QT that gets out of control, we can start stimulating ventricular beats where they shouldn't be. So normally, like when that T is going on, that's my repolarization. And when the QT gets too long, we can pick up another beat too soon. And eventually the ventricles can start firing on their own in a torsades de pointe fashion, right? So that's a polymorphic ventricular tachycardia where we have multiple different foci kicking off ventricular beats. And then that can lead to ventricular fibrillation where the ventricles are just doing this. They're just shooting off all on their own at a very random rate in a very random pattern. And that can lead to sudden cardiac death if we don't get to them quick enough and defibrillate them. Okay. So again, in this lecture, we talked about serotonin syndrome, we talked about neuroleptic malignant syndrome, and then we finished with remembering that serotonin or SSRIs, especially citalopram, can prolong the QT. All right, this hopefully helped you out a little bit. Please email me with any questions you have, and email me if you have topics you want covered. All right, thanks.